So can I have the first slide? It's a simple case whom I think we do tend to see in our clinic day to day. A 45 years old fit lady who has a 2.8 centimeter lump in the left breast. But there is a strong family history of breast cancer in her sister and her mother. No comorbid illness, and she can afford, and she wants the best, right? So I think, next slide, please. Can I have the next slide? So what tests to be done? So that is the question to Dr. Manisha. 2.8 centimeter breast lump, fit lady.
Yes, sir. First, apart from the radiological investigation, I'd like to biopsy her and look for her hormone status, ERPR, and HER2 status. And having said that, since she has a strong family history, I'll be a little more cautious regarding, have a metastatic workup the day one she has entered my clinic. And once I get the report, I'll proceed further.
Okay, so I think that sounds great. The next slide, I think, shows the reports. So since we are dealing with the TNBC, so it is a TNBC on a true cut biopsy, and there is a 3 centimeter tumor in left breast with 1.3 centimeter single axillary node, and the metastatic workup is negative. So what next, Dr. Sajeevan? Next slide, please. Yeah, what next?
Yeah, as you said, she is opting for the best of the best. So with the current information, probably I can discuss the option of neoadjuvant immunotherapy with pembrolizumab and chemotherapy. Though it is not an FDA-approved regimen as of now, and probably not a standard of care, this particular issue can be discussed with her, and if willing, maybe it can be considered as an. I would be preferring for a neoadjuvant approach. Anyway.
So, yeah. Dr. Lee Soo, please. So, what would you like to do before the therapeutic discussion?
So I think I agree with what has been said, and this patient will prefer to give neoadjuvant therapy because it's a 45-year-old and there is family history. We will also typically discuss early genetic testing. In our practice, we still do not routinely use pembrolizumab because it's not FDA approved, but definitely if this patient, it's in a younger patient, we are definitely preferentially at least incorporating.
Yeah, sure. I think great. So Dr. Gaurav, are you there, please?
Yes, I'm right here, sir.
So your thoughts on the further approach to this lady?
Yeah, sir, please, can I get some more information? So this 1.3 centimeter node that is there, was that FNA'd or biopsied, and was it?
Well, it was not. Let me put it this way, it was not.
So I would like to, I think the diagnostic workup is not complete as yet. I would need, besides the mammogram, a good well-performed ultrasound, perhaps by the surgeon himself or herself, and ultrasound guided FNA from this node, because I need to know whether it's a node negative cancer or node positive cancer. Secondly, as you said, there's a strong family history. What is meant by that? What kind of cancers, in which family members, how many of them?
So I mentioned her elder sister and mother has a history of breast cancer.
Oh, I'm so sorry. I didn't pick it up. At what age? At around what age were they diagnosed with breast cancer?
Mm-hmm. So, my question is, how will the FNAC of the axillary node help?
Sure, sir. The FNA of the axillary node would help us both in terms of decision-making now, as far as decision regarding neoadjuvant versus primary surgical treatment is concerned. And then it will also have an impact on eventual, even if the patient doesn't undergo a primary surgery, the eventual definitive surgery post-neoadjuvant chemotherapy.
So Dr. Lee Soo, do you agree for the FNAC of the axillary node?
We don't routinely do that. I think if clinically it's already if you can palpate the lymph nodes, we will consider that it's node positive.
Dr. Manisha?
No, so we don't do FNAC. It's just a biopsy from the primary site. If it's clinically palpable, we go about the staging and the proceed
If
like that
it's a
one.
3 centimeter node, I got the feel from the panelists that a neoadjuvant therapy is on, irrespective of the nodal involvement.
Yes.
So
So
if I may,
I'm little, my comment will be little different because we have a, keynote 522, a positive trial, but then we again have a neotrip trial, which is a negative trial. So at the moment, neoadjuvant, I'll keep it reserved at the moment for the TNBCs because the data that we have are mixed sort of. So if the patient can go upfront for surgery, I think if the surgeons agree to that, I will reserve.
Manisha,
I mean,
surgeon is always willing, so that's not the question. Okay, I think Gaurav wanted to come in. Yeah.
yes. So if I may, both from a practical viewpoint, by going by what is practiced in majority of multidisciplinary by multidisciplinary teams in presence of a palpable axillary node, especially when we are considering neoadjuvant systemic treatment, I mean, I can very safely say not doing FNA at this stage from the axillary node is not the standard of care. Any guidelines, any clinical practice guidelines you want to peruse, they would mention this. And this is precisely what we do. Besides, if the patient is definitely planned for neoadjuvant systemic treatment, I would go one step further. I would put a clip on the biopsy node because that will help us address the axilla in a more appropriate manner following neoadjuvant chemotherapy, because that is what will help us do targeted axillary dissection later on. If we do not do this FNA now, and if you are not certain about which node was positive or metastatic after the neoadjuvant, we would not be able to do a safe and effective sentinel node biopsy. We'll have no option but to do a complete axillary dissection post NACT.
So I think you've made excellent points there, because in order for us to identify the right place where the primary tumor was there and the node was there, involved or not, so you need to put clips so that it helps you subsequently at the time of the surgical decision making, right?
Correct.
So, Dr. Sajeevan, I think there is a debate. I think Manisha says she's not keen on neoadjuvant. So there are two debates going on. One is the role of an FNAC from an axillary node, and the second is the issue of neoadjuvant chemotherapy for a triple negative breast cancer, which is around 3 centimeters in size. So, Dr. Sajeevan first, and then
Yeah.
Dr. Sajeevan.
Yeah, yeah. FNSC, of course, there is no harm in doing an FNSC, but most of the time when we see a triple negative breast cancer with a clinically palpable and radiologically identifiable node in the axilla, most of the time in practice we won't be going ahead with an FNSC. Though, of course, the option of sentinel lymph node biopsy and all this limited axillary decision and all is there still. But considering the biology of the disease, maybe, and that is one thing. So the next part is neoadjuvant. As we know that triple negative is a bad disease, and there are enough and more data to say that they respond very well to neoadjuvant chemotherapy. Often we get complete pathological response very high compared to other tumors, and probably, though we are not in a very confident position to say that the PCR correlates to the overall survival, there is enough data to show that the progression-free survival scores better when you have a more PCR. So there is data for showing that the PCR is better with neoadjuvant chemotherapy in triple negative breast cancer, and probably across the world, most of the people would prefer a neoadjuvant. The threshold for starting a neoadjuvant in triple negative is very low. So this is my take on it.
Right. So especially that after surgery, if there is residual disease in the resected specimen, one can go for maintenance therapy or adjuvant therapy with the capecitabine regimen. So,
Yes.
Dr.
Yes.
Lisa, Dr. Soo Chin, please, can you give your thoughts on the the threshold for neoadjuvant chemotherapy in triple negative?
Yeah, so I think I agree with what Dr. Sajeevan has said. We would actually have a fairly low threshold to give neoadjuvant chemotherapy. So if we don't even need it to be clinically node positive. So
Correct.
if primary tumor is at least 2 centimeter, that's already is a clear reason to give neoadjuvant chemotherapy. And in Singapore, we also do give adjuvant capecitabine in patients who do not achieve PCR based on the CREATE-X trial.
So, Dr. Manisha, I think.
Sir, I have a question here. So, do we give adjuvant capecitabine for all cases? We have a GCAM trial and we have a KIBOM trial, which says that only subset of the TNBCs who were non-basal-like, they had, a response to adjuvant capecitabine. Otherwise, the rest they did not have. And are we doing a molecular testing for these TNBCs to know whether we are dealing with BL type or not? So is it that for all residual tumors, we are giving capecitabine?
Dr. Soo Chin, please.
So we don't do further tests. So we go just strictly by the CREATE-X trial. So if they fail to achieve PCR, we will discuss the option of adjuvant capecitabine with these patients for the triple negative. The CREATE-X trial had HER2 negative, hormone receptor positive. We don't believe the hormone receptor positive data that much because the benefit there is very small. But for the triple negative breast cancer patients, we do offer based on the CREATE-X trial. And we don't do additional tests we don't routinely do that. Yeah,
That's what I intend to say, that we are just, putting our words for CREATE-X, not for the other trial which tested the molecular testing of TNBCs. They categorize the patient who will respond to capecitabine when they have a residual disease on an adjuvant setup. So I just wanted to know, are we doing these molecular testing for TNBCs at your setup?
Yeah, Manisha, I think let me just put this into perspective. So one thing which both the speakers or both the panelists are saying, that the threshold for initiating neoadjuvant chemotherapy for triple negative has really gone down. Any tumors beyond 2.5 centimeters, people are looking at neoadjuvant chemotherapy. That's number one, because of the high PCRs. We're just coming to that. And the second, of course, is the data on CREATE-X. So I think the same thing is happening in HER2 new situation, a positive situation, where you have drugs like pertuzumab and taxanes and Herceptin. So we need to have these kind of debates and discussions in the MDTs, where we need to convince the surgeon. And of course, first of all, we have to get convinced that the neoadjuvant chemotherapy and TNBC, the threshold can be lowered. So that was the idea of bringing in this particular kind of case here. So let's move on.
But one point again, I'd like to add upon. Again, we had data that if we are giving neoadjuvant, even because of a small size, because of the lower threshold that has gone, it is only the BL1 type which is getting the maximum response. Otherwise, if it's some other variant, suppose if it's an LAR variant, it's a luminal androgen receptor variant, that would not respond to neoadjuvant. So categorizing all TNBCs in one, shell and making it a neoadjuvant, it's something that we are practicing, but we are...
So that you are not convinced on giving neoadjuvant. Dr.
No, we have to give, but then the subset BL1, that is a basal luminal type 1, responded maximum to giving neoadjuvant. That was to the tune of 60%, as compared to just 10% if you gave it for the androgen receptor positive TNBCs.
So Manisha, that testing is not possible and nobody is doing it.
Yes.
So therefore,
nobody is doing that in practice.
The TNBC. So I think we need to move on. Please, I think we have a few more minutes to finish it up, please. So there is a deleterious mutation seen in the BRCA as was expected. So I think we've had a discussion. What next is the next slide, please. So chemo versus surgery. I think most people would say chemo. Next, please. So issue is what chemo? So Dr. Sajeevan, these are the options. The patient is BRCA positive, and so the family and the doctor is decided for neoadjuvant chemo. So what option do you want to exercise in terms of neoadjuvant chemo? Dr. Sajeevan, please.
Yeah, actually, you can use any of these combinations. Probably most of the time we use the conventional regimens itself, even though it is neo, even though it is TNBC, and anthracycline taxane-based combinations, either combination or in sequential pattern you can use. There is no real standard of care actually. What all conventional chemotherapeutic medicines which you use for the neoadjuvant regimens we can use. And of course, platinum is also more useful in BRCA mutated tumors.
Would you like to use a platinum or an anthracycline based?
I would still go with the anthracycline and then taxanes.
Dr.
Because
Gaurav?
Yeah, in our MDT, we would almost always, I mean, considering this is a sorry, a T2N1 disease, TNBC, and a high Ki67, a very high likelihood that she will respond well to neoadjuvant chemotherapy. So we will mark the tumor and do FNA, mark the node if it is positive. And then usually we would choose conventional anthracycline-based 4 cycles, followed by 12 weeks of paclitaxel. That is
Or
usually we
followed by T. Okay. Okay. So, Dr. Soo Chin, what is your choice for a BRCA positive TNBC?
This patient, we will give AC followed by paclitaxel plus platinum. We will give paclitaxel plus carboplatin, but it's an anthracyclines, taxanes, platinum sequential regimen.
So you will give ACE4 AC followed by taxane and platinum.
That's and carboplatin.
Yeah, platinum, taxane and platinum, carboplatinum. Okay. So, Dr. Manisha, please, if you have to give, what is the neoadjuvant?
So, at our setup, we are giving 4AC followed by 4 taxane. We are not adding in platinum in the neoadjuvant setup.
So, because in BRCA1 there is data. Dr. Soo Chin, your thoughts?
Yeah, so I think BRCA is the group of patients that is most likely platinums. There is an earlier trial that for BRCA germline mutation patients, just giving 4 cycles of carboplatin, they could induce PCR, which is equivalent to an AC taxanes regimen. So I strongly believe that the BRCA mutation carriers are the ones that use the platinums.
Have the next slide. That's that slide. Next.
You're not audible, sir.
Next slide, please. So I think this is what they were mentioning about the role of carboplatinum in patients with BRCA mutant, where the platinum. So one can opt for platinum-based chemo in a BRCA 1 or 2 positive. Next slide, please. Yeah, I think we'll skip these slides. This is the same data. So this patient was given 4 AC 40. We can go on for a few more minutes if the time permits. This is what Dr. Next, please. Next slide, please. So residual disease, we have discussed about capecitabine. Dr. Gaurav, do you follow capecitabine in patients with residual disease in post-surgery?
Yes, we do. We all high-risk breast cancer patients, not with the exception of elderly, low Ki67, almost all patients are now advised 6 cycles of capecitabine.
So, okay, I think 3 years later, she has lung mets. She's next. So, Dr. Manisha, what would you like?
Yes, so I'll just like to have a repeat biopsy of this patient, and I'll subject it for PDL1 status. And as if I know that the patient had a germline mutation, you said, patient is already BRCA positive. So now at this point of time,
Yes.
I'd like to rebiopsy her and send the sample to know the PDL1 status. And then accordingly, I'll make my planning for the further treatment.
Okay, next slide, please. So she got the biopsy and PDL1 testing. What about NGS? Would you do that, or anybody would do the NGS?
Here we have a BRCA mutated tumor. So maybe at this point of time, at least in my practice, I may not be sending for NGS. If she fails fails subsequently, then at that point I can send NGS. Not in the first line.
Is she there? Dr. Soo Chin, are you there?
Yes. So I do NGS. Yes, we do NGS, but it will not really any real clinical standard options, but because we could then put the patients on clinical trials. Because we have a phase 1 trials, then we could maybe look at those and enroll the patients into some trials.
Okay, so PDL1 is, next slide please. So PDL1 is 50% positive here in this particular patient, and she's fit, she's well preserved with lung and liver metastasis. So what is the, what are you doing, Dr. Soo Chin, these days for PDL1 positive, BRCA positive patients in first line of systemic therapy?
If it's PDL1 positive, then my first line choice is atezolizumab plus nab-paclitaxel. So this is unfortunately a very expensive regimen, but we go strictly by the trial. So unfortunately, at least based on the Impassion 130 trial, the regimen is atezolizumab plus nab-paclitaxel. So you may know that the Impassion 131, which is atezolizumab plus paclitaxel, it was a negative trial that did not meet the.
Dr. Manisha, any thoughts on the more recent data of?
Yes.
Yeah.
So if the patient, as Madam said, that this is a costly drug, prescription, but definitely will like to offer her with atezolizumab and nab-paclitaxel combination. If at all she cannot afford, so for the patient, if she's, both PDL1 positive and she's also a germline positive, that happens in about 15% of the patient. The second, what I'd like to offer her is the advantage of olaparib. Because already you said she has given, having been the advantage of platinum has already been given. So I will give the advantage of olaparib in such cases if the patient cannot afford to get atezolizumab in combination with nab-paclitaxel.
Dr. Sajeevan, your thoughts on atezolizumab, especially after the
Yes. With the recent update, I would prefer to give her atezolizumab and paclitaxel. On the contrary, even if I am not seeing atezolizumab, olaparib is also a. So if she's not able to afford atezolizumab, she will not be able to afford olaparib as well. So given the first choice, maybe atezolizumab plus paclitaxel.
I am in disagreement. Dr. Gaurav, your thoughts?
Well, I have no personal experience with neither olaparib nor atezolizumab. But I think this patient so far has not been treated with any platinum agents.
Correct. Yeah.
So why not just taxane and platinum combination at this stage?
Right. I agree. So Dr. Soo Chin, so what about the recent data of atezolizumab presented in ESMO, where atezolizumab did not show the positive study?
We're talking about Impassion 131, atezolizumab plus paclitaxel.
Yes.
Yeah, so I did mention that just now. So I agree with you. The problem with this atezolizumab data is that there is one positive trial and there is one negative trial. And in practice, it's actually really expensive to combine this with nab-paclitaxel. Whereas the pembrolizumab trial, which is the keynote trial, actually allowed either nab-paclitaxel or gem-carbo. So there are a number of easier to administer regimens. So it's unclear why why the chemotherapy partner should be so important and why there is a difference in the signal readout between the pembro data and the atezolizumab data. But for our institution, we go strictly by the data. But I agree, if the patient cannot afford atezolizumab, which many of our patients cannot afford, then I would preferentially give this patient a platinum-containing first-line chemotherapy regimen.
So let me get this clear. Just 1 minute, Manisha.
Sir, can I ask,
1 minute.
Do we have any head-on trial comparing which is better, either olaparib or platinum? The data, the retrograde data from ovarian trials says that if the patient has taken platinum and the patient has a 6 month of DFI, it's always preferable to start with olaparib. But this is only a retrospective study from the ovarian that we have at the moment. At the moment, do we have any head-on trial telling you which is better, either olaparib or platinum?
I will come to that question. Can I just, we'll come to that question. So before we, Dr. Soo Chin, so in order for us to give atezolizumab, you like to combine this with nab-paclitaxel, right?
Yes.
And not with paclitaxel.
Because there is an Impassion 131 and there's an Impassion 132. They are all evaluating different chemotherapy partners. And the Impassion 131 with paclitaxel is already negative. The 132, which is with gem-carbo, is still ongoing. So we should wait for those data. So I will not combine atezolizumab with any other chemotherapy partners until I see the data.
So you'll combine it with nab-paclitaxel, right?
I have to use atezolizumab. I will combine with nab-paclitaxel.
Okay, so that is the part taken care of. So now the question is, why not give olaparib to this lady who is BRCA positive?
Asking me?
Yeah, Dr. Soo Chin, yeah.
So so why do so I mean, there's nothing wrong with giving first-line olaparib, but in the EMBRCA and the Olympiad trials, we do have about 30 to 40% of patients who are using this as first-line treatment. But if you look at the subgroup analysis, there's no real difference in patients who are receiving this as first, second, or third-line treatment. So you do see similar benefit. Similarly, prior platinums, if you look at the subgroup analysis, there was no real difference. The only exception is in the Olympiad trial when they updated their overall survival data. There was a signal that patients who are receiving olaparib as first-line treatment, they appear to have an overall survival benefit. But this was not seen with talazoparib, and it's a subgroup. So I don't feel that there is very convincing evidence that you must use this in the frontline setting for everyone.
So what is the FDA label for olaparib for breast cancer? First line, second line?
Doesn't say. You just germline HER2 negative metastatic breast cancer with a germline mutation.
Dr. Sajeevan, any thoughts on olaparib?
No, there is no harm in giving olaparib, I think. If she can afford to go for that, she can be given olaparib as well. There is no.
So the guidelines suggest if your patient is PD-L1 positive and she's also germline positive mutant, then you have the choice of giving a PD-L1 inhibitor followed by olaparib. But if she's neither, then the choice is you start with the chemotherapy. Because your patient was positive for PD-L1 as well as she was germline mutant. So this is the question, because this was the criticism of the TNT trial, which took olaparib on the one arm, and the other hand, they took the treatment physician of choice, any other regimen to be used. I mean, essentially, it should have been a carboplatin, the comparative arm. Any platinum should have been a comparative arm to olaparib. But this was not done. And since this criticism, where we are not able to answer how to sequence our, chemotherapy once the patient is not affording or cannot, go with PD-L1 inhibitors.
Dr. Soo Chin, you like to answer?
Okay, for a patient, so if your patient says cost is not an issue, give me anything that my resources can permit, then in this patient, you have to give atezolizumab and nab-paclitaxel as first line, because there are no other times to give your IO combination, because it's not been proven in second or third line. So the money is in the first line. So in order to optimize the patient's choices, I will definitely use the IO combo first. And then second, third line, we can discuss whether it's chemotherapy or whether it's a PARP inhibitor. I think there's no right or wrong answer. But if she wants, the IO has to be in the first line.
So I think it's heartening to see that we have so many options and people are fighting for, one option to be given first or the second to be given first. And then subsequently, you still have platinum, you still have eribulin, you still have vinorelbine and capecitabine if they've not been used before. So I think the landscape of management of TNBC is becoming pretty wide, and patients are seeing several lines of therapy in order to get the maximum out of these. So we really need to follow up some of these studies to see which ones are moving up or which ones are not. And I think we're running pretty late here. So everybody here is feeling a little more drowsy. So I'm thankful.
Do we have any role of VGF today, bevacizumab today in this TNBC? Anyone is practicing, or have we just abandoned this drug?
Dr. Soo Chin, bevacizumab in neoadjuvant therapy.
I rarely use it. I very rarely use it. I don't think that the additional benefit is that much from the trials. So if we do want to give something more, it will be the platinums.
Dr. Sajeevan, you use bevacizumab in TNBC?
No, not at all.
Gaurav, any experience?
No.
In metastatic setups?
So nobody is. I mean, we are not using it in any of the settings, bevacizumab. So it is usually these drugs in a sequential fashion, one after the other are being used. And the first...
In practice, most of the time, we will be using only chemotherapy rather than tislelizumab or even olaparib.
Dr. Manisha did point out about the androgen receptor testing also at some point.
It can be done.
To use enzalutamide, if any. So I think a lot of things are happening in TNBC. And I think we don't have the other drug which Dr. Soo Chin said, which is the sacituzumab. But I think if that drug becomes available, maybe that also can add up. I think we can close it here. And thank you very much for staying awake, staying alive. That's pretty late. It's around 10 o'clock. And we can't offer you drinks. We can't offer you food. So you have to be on your own. And for Dr. Soo Chin, it is even like 12:30, I believe, in the middle of the night. So we are extremely grateful and thankful to you, to everybody, for joining and keeping awake at this time. Thank you all in
Thank you,
all,
sir. Thank you.
Puja and everybody. Thank you very much.
Thank you, sir.
Thank you.
Very thank